Thank you so much for inviting me to speak about this research today. It's a project that we've been really excited about here at Dartmouth. And so I'm glad to be able to share with you today our research on per and polyfluoroalkyl substances in human milk, and a little bit about the work we've been doing to look at associations with the infant gut microbiome as well. So you are probably all fairly aware of PFAS at this point, but just in case it's new to anyone, PFAS are a large group of highly fluorinated persistent synthetic chemicals that are found in a wide range of stain, oil, and water-resistant consumer products, as well as in firefighting foam. They have quite a long half-life in the body, and there are a very large number of highly fluorinated compounds, more than 10,000 depending on how you want to count. And we know that more than 1,000 of these have current uses in industry. So we're very widely exposed to these chemicals in our daily lives. And although PFAS have a wide range of adverse health effects, today I'm going to focus on our recent work investigating PFAS in human milk. And so this really grew out of several prior studies, including one of my own, that had indicated that women with higher PFAS concentrations in their blood breastfed for shorter durations of time following pregnancy. And we don't really understand the biological mechanism underlying that association yet. And it's not entirely clear whether PFAS are influencing initiation of breastfeeding, hormonal pathways that are related to lactation, or to the quantity or quality of milk that's produced. Additionally, PFAS are excreted in human milk, and thus human milk represents an important source of PFAS exposure for newborns. And I'd be remiss not to say that overall, our current evidence suggests that the benefits of feeding human milk to infants still far outweigh the risks from any potential PFAS exposure. But what we wanted to do here was to just understand more about this important pathway of infant exposure. So I was privileged to work with this great team, including Rachel Criswell, Brock Christensen, and Margaret Carragus at Dartmouth, as well as two amazing CHEAR labs to measure PFAS in milk and also to examine qualities of the milk through untargeted metabolomics. So our primary aims from our initial CHEAR project were to examine the correlation of PFAS and maternal plasma from pregnancy with levels found in human milk, and I'm going to talk about that today. We are also investigating associations of PFAS in human milk with the composition of human milk. And so I do want to give a big thank you to Doug Walker for his work on the milk metabolomics. We're looking forward to being able to share those results soon, but that's not what I'm here to share today. So the research that I will share with you today is rooted in the New Hampshire birth cohort study. Enrollment for this study began in 2009, and the cohort's led by Dr. Margaret Carragus. This cohort is ongoing, and we're continuing to enroll pregnancies now. Women are recruited during pregnancy and provide information through surveys and biospecimens, and we then follow the children through adolescence. And so through my Center of Biomedical Research Excellence project, we previously were able to measure PFAS in plasma from 24 to 28 gestational weeks in about 1,000 moms from the New Hampshire birth cohort study. And then in this CHEAR project, it allowed us to extend this to be able to quantify PFAS in milk among about 400 of those mothers. So that milk was collected around 6 weeks postpartum. And as you can see here, the legacy PFAS were more frequently detected in breast milk than in some of the newer and shorter chain PFAS. The concentrations of PFOA and PFOS were also relatively low in the human milk in this cohort. And that sort of tracks with what we saw in the plasma as well. We're looking at sort of contemporary NHANES levels of exposure in this cohort overall, although we do have a lot of variability in the levels that we see in the moms in our cohort. So importantly, PFAS were more frequently detected in maternal plasma from pregnancy than in the milk itself. And so this figure illustrates the difference in the legacy PFAS which were commonly detected in most of the plasma samples, whereas where the PFAS data was already available from the plasma samples. But only PFOA and PFOS were really commonly detected in the human milk samples. And so we are seeing a slightly different profile in the milk than we were seeing in the plasma samples from pregnancy. The levels, however, were very strongly correlated. So on these graphs, we have the PFOA in milk on the left and PFOS in the milk on the right, on the y-axis, and then as compared to the plasma concentrations that we observed on the x-axis. And so both PFOA and PFOS had quite strong correlations between maternal plasma levels in pregnancy and the concentrations that were measured in the milk. But when we look at the absolute concentrations, you can see that the milk had about 2% of the PFOA versus plasma, and the PFOS had about 1% of the PFOS, it was about 1% in the milk as compared to the plasma. So some other things of note included variability according to the week of milk collection. So here we have, again, the PFOA and PFOS on the y-axis, and then the week of milk collection, because we did have some variability in terms of when the milk was collected on the x-axis. And so I want to be a little bit cautious in how we interpret this, because these are not repeated sort of longitudinal samples from the same women. This is just sort of variability in when the milk was collected with our cohort. But it does appear that there was a downward trend, that milk that was collected slightly later in terms of the weeks of collection tended to have lower concentrations of PFOA or PFOS. In addition to that, and consistent with prior research, women with more months of previous breastfeeding tended to also have lower breast milk concentrations of PFOA and PFOS. So we again have PFOA here on the left and PFOS on the right, with months of previous breastfeeding on the x-axis. And so that was added up across prior pregnancies for sort of a total number of months that a woman would have been breastfeeding any of her children prior to the study pregnancy. So coming back to this idea of the low concentrations, despite those relatively low concentrations of PFAS in the milk, due to the high ratio of fluid volume to body mass consumed by infants, we wanted to get a sense of whether this might still reflect exposures that were potentially of concern for the newborns. And so we did this by creating estimates of daily intake as nanograms per kilogram per day. And so we used information on the PFAS concentrations observed in the milk, as well as the infant's individual birth weights. And then for a sense of volume, we used a constant, which was a daily volume of milk intake of 750 milliliters, which is based on sort of average human milk daily intake in the first month of life in the United States. So there will be some variability in reality in terms of the amount of milk that infants are taking in, but this was just to give us a sense of what infant exposure might look like in this cohort. So this is a little bit tricky to interpret because there aren't specific standards or guidelines for PFAS in human milk at this point in time. But the Agency for Toxic Substances and Disease Registry has set children's drinking water screening values. And so for PFOA, that would be about 21 nanograms per kilogram. And so you can see in our cohort that there are a small number of children who are getting levels of PFOA through breast milk, again, according to this estimated daily intake. And for PFOS, that level is set at about 14. And so again, we have like a small tail of infants that may be experiencing meaningful exposure to PFAS through their breast milk. And then again, accounting for the potential that there may be more than one PFAS present in the breast milk as well. And so we want to be conscious of the fact that even in this cohort where we have relatively low levels of exposure to PFAS, this may contribute to meaningful exposures in the children. And so to bring together kind of this first part of our research, PFOA and PFOS from plasma in pregnancy and human milk were quite strongly associated with one another. The concentrations in the milk were substantially reduced as compared to the plasma concentrations, which is good news. But due to those issues of body mass versus volume of fluid consumed, these concentrations may still represent exposures that are concerning. The risk assessment here gets even more complicated in terms of decision-making for new mothers when we consider that formula and baby food also contain PFAS. So if infants aren't eating human milk, they have to eat something. And formula, particularly if it ends up being made with PFAS-contaminated water, can be somewhat problematic. And so this is really an area of critical need in terms of public health guidance to be available to women who are considering breastfeeding, and especially for mothers in communities that are affected by contamination of PFAS. So the next piece of this was that we wanted to start to think about what the health effects in infancy and childhood might be from this PFAS exposure through human milk, because these are largely unknown at this point. And so to get us started in this direction, Dr. Han Ilawi, who's a postdoc primarily supervised by Dr. Margaret Karagas, she's doing very exciting work related to the infant gut microbiome. And here her objective was to quantify the associations of milk PFAS concentrations in a cross-sectional and prospective look at gut microbiome diversity and structure in infants. So we have measures of the gut microbiome from about 6 weeks and then also at 1 year. And so Dr. Ilawi found that PFOS was associated with increased bacterial diversity at 6 weeks. And this has previously been associated with increased odds of early life infection in early childhood. In addition to that, PFOA was also associated with less Bacteroides in the infant gut microbiome. And this is potentially related to pathophysiologic processes that lead to type 1 diabetes. And so we are very interested to take a deeper dive into this and see how the gut microbiome may mediate other known health effects of PFAS, including those immunotoxic effects that I think are of really great interest right now. So next steps for us are to examine patterns of metabolomic features in human milk and how they're associated with milk PFAS, to explore additional factors that may influence the concentrations of PFAS in plasma and milk, including an extended sort of menu of socio-demographic, diet, and lifestyle factors, as well as obstetric and medical history factors, so that we can really help figure out how to identify the women who are at highest risk of having PFAS exposures. And then to continue to investigate how PFAS in milk influence additional health outcomes in childhood. And so I will just close by acknowledging our fabulous team, and especially our collaborators at the Minnesota CHEAR lab that measured the PFAS in milk for us. Both of these pieces of work that I described today are in press. So the plasma and milk work will be coming out in Environmental Science and Technology letters soon, and the microbiome work will be published in Environmental Epidemiology soon. So please keep an eye out for those papers if you're interested.